So you thought you were done with me, but I'm back. So we're going to focus outside the heart now for this morning's theme. And as per my other talks, we'll start with a couple of questions. So the first one is a 63-year-old man presenting to the emergency room for evaluation of severe chest discomfort that woke him from sleep. Gradually resolved after 5 minutes and recurred several minutes later. Over the past few days, he's felt generally unwell. He has not traveled to Italy or China. He's got a temperature, his heart rate is up, his heart sounds are normal. He's got a normal CKMB. I don't know where they're checking that still, but that's still there. His troponin T is mildly elevated. He's got a white count, and his SED rate is elevated. And there's a representation of his ECG here at the bottom. And before I advance the slide, you can take a look at that. And I'm going to ask you about the next step in this person's care. So, should we do a cardiac MRI, start him on prednisone, start him on indomethacin, or do a coronary angiogram? Okay. Question number 2. In which of the following situations is pericardiocentesis recommended? Post-cardiac surgery with an effusion, normal heart rate and blood pressure, but Doppler variation on his follow-up echocardiogram. A young patient with chest pain, a moderate-sized effusion, and widened mediastinum on chest X-ray. A moderate-sized effusion with normal Doppler flow velocities on echo, with normal blood pressure and a markedly elevated sensitive TSH. Or a moderate-sized effusion in an asymptomatic breast cancer survivor 8 years following last evidence of disease. Yeah, it follows the pattern. The second question is always harder. So we're going to cover these topics on the American Cardiology certification boards. There's about 180 multiple choice questions, and about 3 to 5 of the questions are on pericardial disease. So it's an interesting topic because we don't see it enough and we have to talk about it, but it ends up not mattering for their board examination in terms of pass-fail that often. In the US, we also do not have a guideline document, so we are using the ESC one, which is now 5 years old. It really is quite a good document, so I would use it for reference, again, because we don't see that much pericardial disease in our clinics, so just make sure you have a copy of it. So the first objective is going to be to talk about acute pericarditis. That was the first case I presented, obviously. It wasn't so much of a mystery diagnosis, but maybe how we should manage it. A couple of key points about acute pericarditis. Chest pain is the most common symptom. The friction rub that we all like to talk about can be intermittent. It isn't always there, and it can be quite positional. The other thing, many people filter out the pericardial friction rub when they're auscultating the patient because they think it is some sort of chest hair on the stethoscope, or they're listening through a t-shirt and they don't hear it because it's a type of sound, this scratchy noise that we typically filter out when we're trying to focus on S3s and S4s and those kind of things. You ignore those high frequency sounds. So have the patient get in different positions, particularly hard in the hospital wards to hear this because it's just so much noisier there, but it can be found in many patients. The classic ECG is the diffuse ST elevation and or depression of the PR segment, which can be seen, and it isn't in a coronary vascular bed territory. So those are the clues. It's also the shape of the ST segment is concave upward rather than convex upward. Those would be your clues, but it's really the clinical story of someone who either is the wrong demographic for coronary disease, has that kind of viral syndrome leading into it. Those are the typical findings. So it's felt to be due to inflammation of the pericardium, probably viral in most cases, but certainly idiopathic if nothing else. The classic history, a rub if you can find it, markers of inflammation, and it says sedimentation right here, but CRP is being used more and more frequently to assess that, and the ECG findings. A troponin, checking a troponin is now very useful because there can be myocarditis in addition to the pericarditis. And so if you check a troponin and it's elevated, then you need to follow up with MR imaging to make sure there isn't a substantial component of myocarditis there, because if there is, you're going to end up treating this patient more like a myocarditis than a pericarditis. So the patient that we presented in the beginning, their troponin was elevated, so I would say the next step is probably to check the MRI in that individual to make sure there isn't substantial myocardial inflammation, which may influence your care. In the guidelines document, there is this figure that talks about whether you have to hospitalize a patient with pericarditis or not. So if they have any of the markers there on the left-hand side of the screen, a fever, a big effusion, tamponade, those types of things, you might want to put them in the hospital. If in the absence of those features, you're going to start them on empiric therapy, follow up with them in 7 to 10 days to see how they're doing, and as long as they're doing well, they can be managed entirely in the outpatient. The treatment of choice, used to be non-steroidals, but now 10 years ago, 15 years ago, the addition of colchicine has been shown in multiple trials to improve the outcomes of patients with acute pericarditis. One thing is we tend to stop the non-steroidals a little too quickly. If it's a relatively minor case, you can probably give them a week, but usually we're talking about 2 weeks of non-steroidal therapy, and you might even consider tapering that, as it says on the slide, for a few weeks thereafter. The abrupt cessation can lead to reflares of the inflammation. So in the guidelines, it is recommended that you choose one therapy from each box for our patients with acute pericarditis, some sort of non-steroidal, and those are some typical doses of medications we might use, and then colchicine, dose based on body weight. The colchicine is maintained for 3 months from onset of symptoms. Definitely protect their gastric system if you're going to use non-steroidals for this long. And you can follow the patient with CRP if you want to. Again, if it's a relatively minor first ever event, I don't think that you need to force the patient to keep on getting blood tests to check their inflammation. You can talk to the patient and find out how they're doing and how they respond to the taper of their medications. Now, if the patient has recurrences, so they keep on getting pericarditis, that's recurrent pericarditis, and we start to change the game there. That's when we want to use CRP to help us make the decision about when it's time to taper. We're going to make sure we do the non-steroidal taper over a longer period of time, so definitely up to that month of non-steroidals, maybe and decreasing doses. But you're also going to extend the colchicine interval to 6 months rather than 3 months for those individuals. If that's not effective, then this is when we consider steroids. Remember, steroids are going to be highly effective acutely at relieving pain from pericarditis, but it does lead to a higher rate of recurrence of pericarditis. So we reserve it to people who have failed this attempt at longer non-steroidal therapies. Look at the recommended tapering interval of the steroids, half a year. So again, we have a tendency to want to get people off the steroids for all the reasons we've been taught, but if you taper them too quickly, their inflammation will recur. It's also really important to counsel the patients, particularly when you get to lower doses, say 10 milligrams of prednisone or below. Every time you decrease the dose, they are likely going to get recurrence of their chest pain for 2 or 3 days. If you counsel the patients to hang with it rather than readjusting the steroid higher, you're more likely to have success at getting them off of that steroid than if you keep reacting with higher doses of steroid. So it's a lot of management of expectations for the patients and yourself to not react to the chest pain coming back for a couple of days. All these immunomodulating agents have become more and more useful. Patients who are super refractory. I have not had to use these other than in one patient of mine. Super effective, but again, it's a long taper of each of the other agents you're using at that point. We have done an occasional pericardectomy for truly refractory acute pericarditis or recurrent pericarditis. It's not particularly something you want to get into, so it involves a radical pericardectomy, so the whole thing has to be removed, which can be a multi-hour operation, and the patient may still have epicarditis afterwards that can still cause chest pain, because they're going to have all kinds of inflammation after you do cardiac surgery on them. So these are patients that you're doing lots of counseling about chronic pain management, actually, and then they might still choose to get a pericardiectomy. As I mentioned, if they have myopericarditis, you have to be careful about what you do with those patients. So you want to, the MRI is to make sure there's no extensive myocarditis. I'm not going to give cutoffs on what's extensive and not extensive. That's a clinical judgment, because there might be a little bit of inflammation just on the epicardium there. And if it's a minor degree, then treat them like pericarditis. If they truly have myocarditis that happens to have a little pericarditis with it, then you're going to treat them more like a myocarditis patient that Dr. Kushwaha talked to you about the other day. If they are the right demographic and their troponin is elevated, yes, you're probably going to want to exclude coronary cause for elevated troponin. You probably want to put these people in the hospital until their symptoms resolve. And then in terms of athletes, and specifically in the guidelines, it talks about those who are in military service. If they have significant myocardial involvement, you want to keep them out of active duty or competition for 6 months from the onset of their symptoms because of concerns about arrhythmias while the myocardium is inflamed. All right, moving on to pericardial effusions and management of pericardial effusions. The likelihood of symptoms and or cardiac tamponade is directly related to the rapidity with which the effusion develops. So slow developing effusions like seen with thyroid disease, etc., typically cause minimal symptoms and minimal cardiac embarrassment. But a rapidly accumulating effusion can cause people to feel unwell very quickly. The Doppler findings are super sensitive. So anyone who's does echocardiography knows we can see these variations in mitral inflows that we'll talk about in the face of constriction, but those occur probably in most patients before the patient is symptomatic. We probably don't need to intervene on Doppler findings. We need to intervene on the clinical syndrome of cardiac compromise due to the effusion, not due to the Doppler findings. The classic echo findings are obviously the effusion around the heart, diastolic compression of the RV. So the RV should be at its biggest, but you still see it not fully filling in the space it should be. You can see the right atrial free wall kind of waving in the wind when pericardial pressure is equal to right atrial pressure. The IVC is going to look big. And then you can see some of that abnormal septal motion we see in constriction as well. These are some still frames. The short axis view here shows the RV should be filling in this space here, and this free wall is compressed. And then this is what it looks like on M mode. In this late diastolic, the RV should be up here. Pericardiocentesis is recommended for patients who have the clinical syndrome of cardiac tamponade. So that means heart rate, blood pressure perturbations, low cardiac output, those types of things. You should do it if you need to make a diagnosis. Why does this patient have a pericardial effusion? You definitely don't want to do it if you think that the patient might be presenting with a syndrome of aortic root dissection that is retrogradely dissecting in the pericardial space. Obviously, that would be a bad thing to draw the blood out of that space at that time. That's a cardiac surgical emergency. Let me go back to this slide, actually. So when do you need to make a diagnosis? And the question I asked you, the woman with the prior breast cancer, is the correct answer to that question. Breast cancer is notorious for having long intervals of disease-free and recurring as malignancy, as metastatic malignancy. So if you have someone with a prior history of cancer and they have a late pericardial effusion, you need to go in there and get cells for cytology to see if that patient's having a cancer recurrence. All right, now we're going to talk about this diagnostic conundrum of constriction versus restriction, because most of their history exam, ECGs, and chest x-rays can look pretty similar. With respect to constrictive pericarditis, heart failure is the principal presenting symptom, and it's right heart failure is the primary thing. Massive lower extremity edema, ascites, jugular venous pressure is elevated, the liver is enlarged. I don't know. Do 50% of you hear pericardial knock? I'm not sure I've heard one. It's maybe Titus Evans, who's one of our physical examination gurus, hears those all the time. But the point is, it's right heart failure. Signs of right heart failure is what you're going to experience. In the Mayo Clinic experience, the most chronic constriction is due to prior pericarditis, unknown, or prior cardiac surgery are the main causes for having constrictive pericarditis. Radiation therapy is important, again, in your patients who have a prior history of malignancy and had chest radiation. This would have been women with breast cancer probably 20 years ago. This is a long process, and before they were shielding the cardiac structures well. The other one would be Hodgkin's lymphoma, had a lot of chest radiation. So patients with that in their history presenting with right heart failure should be a trigger to think about constrictive pericarditis. This is a neat video of someone who has the classic neck veins of someone with constrictive pericarditis. So this person is sitting upright, so they're sitting at 90 degrees, so you can see he has massive elevation of his JVP, but he also has those very prominent X and Y descents. You actually appreciate the collapsing of the neck veins as much as you appreciate how high they are. The diagnostic tests we typically do, probably in the wrong order in terms of effectiveness, but echocardiography is really a gold standard. We tend to do CT and chest x-ray in most of our patients. We do these in special circumstances. On the chest x-ray, the classic finding we'd be taught about is that there's pericardial calcification. This occurs in 25% of our patients, so again, the absence of pericardial calcification doesn't really help us. Pericardial calcification is also classically taught as being associated with tuberculous pericarditis. On the CT scan, what you're looking for is pericardial thickening, and we see that in about 80% of our patients with constriction. So that means 1 in 5 patients with constrictive pericarditis will have a normal thickness pericardium. So again, don't let this test move you off a diagnosis if every other clinical sign is pointing you towards constriction as the cause. So how do we distinguish constriction from restriction? They have similar hemodynamics, and these are the pressure tracings there. Obviously, restrictive cardiomyopathy is a muscle disease, and constrictive pericarditis is not a muscle disease, it's a pericardial disease. But they both have this dip and plateau trace on the LV and the RV. And so how do we determine these? Classically, we've been taught that signs for restrictive cardiomyopathy include that the LV EDP is always 5 millimeters higher than RV EDP, and the EDP is less than a third of systolic pressure. Those are classic findings, but the reality is don't pay attention to that last slide, because here's the overlap in these findings between all of these things. For an individual patient, those tools are not going to help you decide whether a patient has restrictive cardiomyopathy or constrictive pericarditis. What we really need to do is look at the hemodynamics of this. And the hemodynamics are particularly notable during the respiratory cycle. And you need to look at full respiratory cycles to see if you can find dissociation of intrathoracic and intracardiac pressures and increased ventricular interaction. What do I mean by that? So normally, when we take a breath in, our intrathoracic pressure drops. But because the heart is in the chest, the absolute pressure within the right atrium also drops, so the heart and lung pressures change relative to one another. In constriction, the heart is insulated from that intrathoracic pressure change. So when you take a breath in, your right atrial pressure doesn't drop, but your intrathoracic pressure drops, and you get this big pressure gradient from your IVC into your right atrium, and you favor filling the right heart. At the same time, because you're dropping intrathoracic pressure but keeping left atrial pressure the same, the driving pressure from the pulmonary system into the left atrium is reduced. You are reducing the drive to fill the left atrium. So with the breath in, you are enhancing filling of the right heart, decreasing filling of the left heart. With a breath out, intrathoracic pressure raises, and you reverse that. You increase the gradient from the pulmonary vasculature into the left atrium, so blood flows into the left atrium. You decrease filling from the IVC, so you decrease that kind of filling. You can see this in the cath lab because you'll see your wedge pressure changing and your diastolic pressures in the RV and the LV not changing. That would be the hemodynamic pressure trace that you would see. In the echocardiogram, this is a video that my colleague J.O. put together to explain what I just said visually. So as this video starts to play, as you take a breath in, intrathoracic pressure drops, but because the abdominal pressure is dumping blood into the right atrium, you're going to enhance filling here. The driving pressure from the pulmonary veins into the left atrium decreases. So a breath in, higher tricuspid and hepatic velocities, lower pulmonary vein, and mitral velocities. When you exhale, the opposite occurs. So in the echo lab, we're going to focus on mitral inflow, and actually hepatic veins are the most reliable ones to look at. And if we see changes of 20 to 25% in these velocities between inhalation and exhalation, then we start to really think about constrictive pericarditis. Now, both in constriction and restriction, you're going to see an E predominant, high E, short deceleration time, low A. And one of the really neat things to look at is the tissue Doppler velocities. Because if it is the muscle that's sick, your tissue Doppler velocity will be very low. When you have a restrictive cardiomyopathy, your E prime will be very low. It'll look like this as compared to normal. In someone who has isolated constrictive pericarditis, the muscle is normal, but it can't expand laterally because of the pericardium. So it can only fill longitudinally, which means your E prime is going to be enhanced. So you'll see a patient with constriction have a supernormal E prime. This is great if it's isolated. In those cases where radiation therapy might be the case, remember the myocardium can be affected by radiation just like the pericardium, so those are going to be hard to figure out. You're probably going to have somewhere in between these two, and that won't help you. But if you see this, think muscle. If you see this, think pericardium. Now, if you are still confused after you've done the echocardiogram and you need to do a hemodynamic catheterization, you want to do a simultaneous LV-RV, you want to do that wedge pressure that I talked about, and this is a tracing from someone with constrictive pericarditis. How do I know that? If you look at the LV pressure curve going down during inspiration and the RV pressure curve, you can see that they're moving in opposite directions during the respiratory cycle. This is the ventricular interdependence. When you see the LV and RV getting bigger and smaller out of phase with one another, that's constrictive pericarditis. In contrast to this patient with restriction, the LV and RV are getting bigger and smaller in phase with one another. That is restrictive cardiomyopathy. These are those same two pressure curves, just with arrows to enhance that. So this is the few cases that we have to do that need a cath. This is what we're looking for in our cath, is this ventricular interdependence. We send many of our patients for pericardiectomy without going to the cath lab now because the echo lab has gotten so good at distinguishing out those other features, but we still have a substantial number that need this type of evaluation. So for constrictive pericarditis, remember you're looking for respiratory variation in the Doppler, particularly the mitral and hepatic. You can see the septum shift from the right to the left during inhalation and from the left to the right when you exhale. Remember the E prime is going to look normal in constriction or supernormal. The myocardial strain, if you're doing that, should look normal in isolated constriction. BNP is not usually elevated in constriction. And the LA is not markedly enlarged in constriction, whereas in a restrictive cardiomyopathy, that's one of the pathognomonic signs are those giant atria. The treatment of chronic constrictive pericarditis is surgical, and it is and we advocate for complete pericardiectomy. We don't think windows work. They work temporarily, and then they seal off, and the patient still has constriction. So we do a radical pericardiectomy. Those operations do take 4 to 5 hours because it's often adherent to the epicardium, and it takes a long time to get the right plane for the surgeon to find that. The one case where we advocate using steroids early is a post-op patient with acute transient effusive constrictive hemodynamics. So this is an early post-op patient with an effusion and signs and symptoms of constriction. We will use steroids at that case with a taper over the first couple of months following surgery for patients have that, because that seems to be preventing the late occurrence of constriction if we treat it aggressively. Think about constriction when there is right heart failure out of proportion to any other findings on the echo. So the RV function is normal, the LV function is normal, there's no valve disease, and yet they have this gross right heart complex. Think of constriction. Think of constriction and when there's heart failure and prior breast cancer or Hodgkin's lymphoma, as I said, particularly if they've had chest radiation, and if they've had prior cardiac surgery. All right, our last subtopic on pericardial disease is about masses related to the pericardium. So these are images of someone who has a pericardial cyst. So this massive abnormality in the chest X-ray here. Here is a big pericardial cyst there, and anteriorly here. The nice thing is these are usually benign and usually don't require us to do anything. They occur rarely. You can see them with echo, but CT and MRI are probably a better way to get the full extent of them. They are only symptomatic if they get caught between the rib cage and, say, the RV, and they start to compromise RV filling or those types of things. People have tried to just drain them percutaneously. It can work, but they tend to refill, and so sometimes resection is needed. Pericardial malignancy is almost always metastatic, and typically from these organs: lung, breast, esophagus, hematologic, and melanoma. So if a patient presents with a cancer history and they have a fusion, you have to prove it's not cancer before you go other directions. Couple of summary slides again. For tamponade or for diagnosis, we do all our pericardiocenteses in the echo lab, actually. Well, we don't do them in the echo lab, we do them in the CICU, but with echo guidance, because it's very easy to find the shortest path between the chest wall and where the biggest fluid collection is. Super safe and effective practice. If you do this and these pericardial malignancies have pain, then you treat them with nonsteroidals. Remember to recognize the pathognomonic ECG of acute pericarditis. Remember to use both nonsteroidals and colchicine as first-line therapy and to taper those. 3 months for the colchicine, at least a couple of weeks for the nonsteroidal. Only tap if they have clinical syndromes that require tapping, not just Doppler findings. And remember those hemodynamics of constriction. So I've already given you the right answers here. Elevated troponin should automate MRI. Yes, most of you answered indomethacin, which is going to be the first-line therapy for this person, plus the colchicine. But because of this troponin being elevated, we need to do this as the next step in this individual. And there was a split on this. So this post-op patient with normal velocities, no clinical signs of tamponade, I wouldn't intervene on that patient. You're going to have a higher risk of causing an infection in the early post-op period, so just watch how that patient does. Obviously, wide mediastinum, aortic dissection needs to be our thoughts there, so don't want to do a tap. And this one with severe hypothyroidism and no symptoms, you can probably just treat their hypothyroidism and don't need the fluid for diagnostic purposes. Thank you very much.
That was just fantastic. We were going to have a few minutes for questions here. It was a high-yield presentation. Let me give you one clinical case while we think of questions. Straightforward acute pericarditis, patients in AFib. The heparin and risk of bleeding, do you worry about heparin?
Yeah, well, you worry about any patient who you're going to have to give non-steroidals to and anticoagulate at the same time. On the other hand, you're treating a real problem and trying to prevent a potential problem, and I usually say treat the actual problem that's in front of you and then deal with the consequences and use gastric protection for those individuals, those types of things.
And bleeding into the pericardial space and worsening an effusion?
Yeah, that's a great question. So yes, that is a potential risk, and if we see the pericardium, if we see an effusion enlarging, so if you are doing that patient, you're probably going to image them again more soon. Yeah.
Fantastic. Questions? We have a bunch of questions.
Yeah.
Thank you. In terms of diagnosing acute pericarditis, it's all well and good for ESC to say you need 2 criteria, but as you mentioned, only 60% of our patients have ECG findings and effusion. So I tend to just go with 1 criteria, i.e. classic chest pain. I don't know how much of that is acceptable, or do you still stick to 2 criteria?
Yeah, I think that's a great point. If it's a young person with no comorbidities and they have a classic story for acute pericarditis, I think you're right. I think you treat that. I think you need to be more secure in finding other criteria if they have comorbidities that might affect your treatment choice, as Rajiv just suggested. So if they're on anticoagulation and you're worried about starting them on something, you might want to be more secure. But yes, your clinical judgment, your pre-test probability is probably what you're going to go on in most cases.
Thank you for the excellent talk, Professor. My question is about the role of cardiac MRI in constrictive pericarditis. Because would you not recommend to do like an MRI in every case of constrictive pericarditis before referring them for pericardectomy? Because we know that the presence of myocardial fibrosis and atrophy actually increases the mortality, surgical mortality. So would you not recommend to do it in every case of constrictive pericarditis?
I try to avoid words like every, never, and always. But it's a fair point, particularly in those cases where they do have underlying disease that can result in both myocardial and pericardial involvement. If you do an MRI, so they have the radiation history, and you can see they've got fibrosis, yes, that's probably going to impact the way you counsel your patient. It might not change whether you end up doing the operation or not, because at least you're taking one of the two issues out of the way, but you would counsel them about their prognosis differently.
Mark, I want to shout out. Oh,
yeah. So I was just going to say, but if it is a pretty straightforward that there's no evidence of other reasons why the myocardium should be involved, and there is a reason why the pericardium should be involved, I probably wouldn't do an MRI just empirically. No.
Go ahead.
Thanks, Steve. Great talk. Really enjoyed it. Great takes. I always have to refresh myself on this. One comment, one question, if I may. Comment: I wouldn't do the immediate MRI on the patient coming in if the troponin's elevated. I think we take a more nihilistic view, not least because MRI isn't immediately available. Just say it does not come from the pericardium. You have to have myocardial involvement. So you have got myopericarditis by default. That's just the comment. Second thing. The last person I had, I was all for taking someone to the cath lab for hemodynamics. We were fairly sure they had constricted pericarditis. Good story, proper calcification on the lateral chest film. I consulted with some colleagues, one of whom is a real echo expert. Both said go for MRI for diagnosis, which you didn't mention. Eventually I did, surgeon accepted that, and we didn't have to do it. I was quite looking forward to doing pressure measurement things because I get so little. So I just wondered what you thought about MRI as a diagnostic modality.
Yeah, so I did have it there under special circumstances, and so I have tended to use it in the patient in whom you were reluctant to go to the cath lab for some reason because maybe they were frail or they had tenuous, renal status, and you didn't want to give them, but that would be an issue with gadolinium. But you're looking for pericardial thickness and pericardial inflammation that you might see on the MRI, so it can be very helpful. In our practice, we don't have to get it in most of the patients because I think between the echo and then our cath lab doctors won't give that up. So Nishimura won't let me not have him do the hemodynamic cath when I'm confused. So, but it's not unreasonable to consider an MRI as an adjunctive diagnostic.
Question in the back.
We always learn that constriction occurs late after bypass surgery, but we also have the experience that it occurs early after surgery. Could you comment on that? What's your experience about it? And you mentioned something about treatment.
Yeah, so that's usually there's an effusion, and so usually you see an early effusion in constrictive hemodynamics, and those are the patients in whom we do use steroid right away in their treatment and don't mess around with the nonsteroidals, in part because they've just had surgery and those types of things. But then you want to keep the steroid on for at least a month, start tapering it. You probably want to add colchicine to that as well and keep that on for 6 months after the operation. So that early constriction is a reversible form of constrictive pericarditis.
Steve, on the acute pericarditis and the colchicine, it's regardless of the cause of pericarditis.
Correct.
Is there any group that responds better? I mean, does the viral patient respond better to the immune patient?
I'm not familiar with any data that would suggest that.
Could you comment on chronic pericardial effusion in a patient that is not hemodynamically compromised, and how do you treat them? How do you follow up? Do you sometimes do pericardial synthesis at some point in time?
Yeah, so I do have a couple of patients who simply have isolated chronic pericardial effusions, and I try to forget that they have it because we're always worried about it, and they truly have nothing else going on. If they, again, have other comorbidities, or there's any hint that they might have a connective tissue disease or those kind of things, sometimes you want to do the kind of, the old assessment to see if you think it's a transudate or exudate and those types of things, but usually in the absence of symptoms and in the absence of likely comorbidities, try to ignore it.
More questions? Yeah.
In chronic kidney disease patients, how would you use non-steroidal anti-inflammatory in terms of the length of course, and how would you taper off these drugs?
So
in chronic kidney disease patients?
So in chronic kidney disease, you're stuck a little bit. You might want to go with aspirin as your non-steroidal because it's a little bit easier on the kidneys than the indomethacin is, for instance. You would definitely want to use colchicine in those individuals. So you want to probably shorten the course of the non-steroidal, go with aspirin as your agent of choice, and then keep the colchicine on for a little bit longer.
Thank you very much for what's probably the hardest thing, I think, in cardiology, especially at the front line. We probably look after pericarditis a bit differently. I've seen loads of cases that I never even hear about, front door pericarditis. The small troponin rise, I think we often just put down to a little bit of myocardial involvement and then just shrug it off. But my question really is, at what point would you think that you wouldn't give NSAIDs to a patient with myocardial involvement, even if they thought they were typically pericarditic?
Yeah, I agree with your comment, with other comment. If it's a really low level elevation like it was in that test question, you probably would just say that's not substantial myocardial involvement at that point and probably just treat that like pericarditis. If the troponin is very high and you're getting the MRI and it shows a pretty significant amount of myocardial inflammation, then you're going to switch over and treat them more like a myocarditis patient, and you might consider steroids rather than a non-steroidal with a lot of myocardial inflammation. But yes, I agree that a little bit of troponin leak is probably just a little bit of epicarditis, and you probably don't want to change your treatment course for that.
Steve, thank you so much again for a wonderful series of lectures. I really appreciate your time. Everyone, I'm sure, feels a lot more encouraged and enlightened and enthralled about these conditions. Steve, thanks again.
Thank you.